Hi, good afternoon. I'm George Kaufmann, president of Nami, Santa Barbara County, and this is the workshop on implementing.
Real quick, can everyone hear that? I just want to make sure everyone can hear that real quick. Oh my God. Where did my controls go? Technology, y'all.
It seems like some folks can hear it, but the volume was a little bit low for some folks.
Okay, thank you so much.
Mm-hmm.
And then if one of you can just click on admit all in the participants box, so just in case people are trickling in, I'm gonna go back to sharing. Oh, where did it go? Okay.
Implementing CIT training and mental health crisis co-response in a mid-sized county. Our speakers today are Lynne Gibbs, who's the chair of our local Nami's Public Policy Committee, Dr. Cherylnn, Behavioral Sciences Manager for the county's Sheriff's Department, and John Winkler, Division Chief for Clinical Operations, the Department of Behavioral Wellness in Santa Barbara County. Next. So a little background before we get started. How did we come up to develop this program that you're going to hear about today? First, probably like a lot of your counties, we've experienced a very high percent on any given day of folks in the county jail are known to have received services at some time from our mental health department. The first item up there is important too, that the business of nonviolent mentally ill offenders in jail is something that's a deterrent actually to our families and trying to get help for their ill relatives. We actually have people that are afraid to call 911 because they don't want their family member arrested. There's been an impetus for change too. We have several local stakeholder initiatives in our county, a crisis action team, a forensics action team through our mental health department, the Department of Behavioral Wellness, Community Corrections Committee, and more recently the Stepping Up initiative, that national initiative that's implemented on the local level to keep more people with mental illness out of jail and into treatment. So anyway, the consensus from all this data and all these stakeholder initiatives is that we needed a much more robust crisis intervention team training program and crisis co-response team. So the way that we're going to go today is we're going to hear first from Lynne Gibbs from the community stakeholder perspective, and as I said, she chairs our public policy committee. And then Cherylnn will talk about the role that the Sheriff Department has played. And finally, John Winkler, the role that our Behavioral Wellness Department has played. Lynne?
Hello, slide 1. The mission of the Nami Santa Barbara County Public Policy Committee is to educate and advocate for a robust continuum of care, ensuring a right to timely treatment for people experiencing mental health issues. Slide 2, please. Our Public Policy Committee studies and takes positions on legislation, generating support at the grassroots level. We organize legislative letter writing and testimony at hearings. We communicate our positions to elected officials at all levels. At the county level, our members participate as stakeholders in the public mental health system, interacting with county departments, the county CEO's office, and the Board of Supervisors. We serve on the county Stepping Up Committee with the charge of reducing the incarceration of persons with mental illness. We serve on the Community Corrections Input Committee, recommending and tracking healthcare improvement at our jail. Our committee serves as an authoritative community resource for information about public policy issues. We advocate on issues of concern to our members, who are family members, peers, and community members, collaborating with groups such as the Santa Barbara Coalition Against Gun Violence and our downtown business organization. And our meetings are open to everyone. Our Nami affiliate loves that we get to bring a panel of peers and family members to our CIT academies to tell our stories and interact directly with law enforcement. So Cherylnn has given us the name the Happy Helpers, which we're glad to have. Here I'd like to tell you about our advocacy for a robust crisis intervention team training program and a highly successful co-response program that Cherylnn and John will tell you more about. Next slide. How did we get here? It began a couple of years ago with planning for the first CIT Academy and a modest co-response pilot program leveraged by volunteers and extra help dollars in the county. Dr. Lee, the Behavioral Sciences Unit Manager, presented to our Public Policy Committee on several occasions on CIT and co-response, designed to de-escalate and divert those with mental illness from arrest. And at those meetings, our members told Dr. Lee about how successful the program has been and how much the family members appreciated the pilot. When we subsequently got word that our single co-response team was about to be disbanded due to budget considerations, we organized and we met with our sheriff. At that meeting, we had representatives from our Nami affiliate, from the League of Women Voters, from Clergy and Laity United, which is a group, social justice group from the various religious organizations in town. We had someone from the Band of Brothers, a veteran support group, and someone from Families Act, a Santa Barbara organization that has historically focused on dual diagnosis and incarceration. The co-response pilot was saved until budget time, and then during county budget workshops, we stood before the Board of Supervisors and told our personal stories. We advocated for a budget expansion to fund the full-time position of Behavioral Sciences Manager at the Sheriff's Department. This was not without pushback, but the position was approved. It has since proven its weight in gold, engendering grant-funded programs to extend co-response to multiple teams throughout the county. With our county's expansion of grant-funded diversion programs, we now want to focus on the gaps in continuity of treatment when our most ill leave the jail so that they don't circle back. And so our advocacy focus this upcoming year will be diversion to what? We are encouraged at the progress we've made, and we're enthusiastic about the work yet to be done. Thank you. And on your screen is a list of what we think of as advocacy components. I won't go through them all, but one thing that's important to note is that sometimes we need to circle back so that we might define the problem and then redefine it. And last slide is a bibliography of articles that we think are relevant. And you can take a look at these later. Thank you.
Okay, Cherylnn.
And our next speaker is Dr. Cherylnn Lee from the Sheriff's Department.
Thank you, Lynn. I appreciate the introduction from you and the happy helpers that I know are behind you, helping you craft this. So thank you. It's nice to be here. My name is Dr. Cherylnn Lee. I'm a first responder psychologist and the behavioral sciences manager for the Santa Barbara Sheriff's Office. Next. Next. So a little bit about my background. So I have a doctorate and master's degree in clinical psychology. In addition to working at the Santa Barbara Sheriff's Office, I'm also in private practice where I see first responders exclusively for therapy. I'm also board member for CALM, which is an organization that assists with children who are at risk of trauma or have experienced trauma. And then prior to working in the law enforcement field, I did a lot of work in psychiatric treatment at various hospitals from San Diego up to San Mateo. And I've worked with folks with opioid use disorder in the Santa Barbara area. Next. So typically when psychologists are embedded within law enforcement organizations, it's to do pre-employment psychological screening or fitness for duty. That is not what I do at the Santa Barbara Sheriff's Office. So as Lynn and George mentioned, this unit or this program started on a volunteer and collateral basis. So I started with the Sheriff's Office as a volunteer in 2015. And we had a group of volunteers from the Sheriff's Office of different deputies who were interested in doing more to help the population of the mentally ill. What we were noticing is that there was an increase in the number of calls for folks that were mentally ill and an increase in the jail numbers of folks that were experiencing mental illness. So we started with an 8-hour CIT, Crisis Intervention Team Training course. And during that course, a lot of our deputies and officers spoke up about the systemic failures they felt like they were facing every day out in the community. There was a lot of hopelessness and frustration surrounding these calls. They're often complex, and what we noticed is that law enforcement wanted more tools. They wanted more help in dealing with this population to get them the help that they needed. So we started attending county meetings, some of which included the Public Policy Committee that you heard about. Then the Sheriff's Office hired the Behavioral Sciences Manager, myself, as part-time in 2017, and the position was fully adopted by the Board of Supervisors thanks to the advocacy Lynne was talking about in 2018. So the position has been full-time for about 2 years now. Next. Okay, so what are we doing? There's quite a lot that we do. There's two main arms of the Behavioral Sciences unit. One is training and the other is operations. So we've expanded beyond just the 8-hour CIT course to a 40-hour academy. We also have a 24-hour academy for our custody deputies that specifically focuses on issues in the jail. We have a course for dispatchers on how to handle suicidal callers and how to develop their own resiliency. And we're also focused on assisting our deputies and officers with their own wellness. So part of my role at the Sheriff's Office is I am on call 24 hours a day, 7 days a week. So if there is a crisis in the field and a deputy needs help getting a person from point A to point B, if there is a significant call and they're working on de-escalating somebody, they can run that information by myself, and I can give pointers depending on the information we have at the time. I'm a part of the hostage negotiation team, so whenever we have a SWAT call out, I go out on scene as well. I also manage, along with our Department of Behavioral Wellness, we jointly manage the county's first co-response program, which is a big part of what I'm going to talk about today. Next. So when we started developing the Behavioral Sciences unit, we wanted to start with data. So what was the status of the mental health problem in our county as it intersected with law enforcement? So interesting, Santa Barbara is the only county in California where law enforcement cannot write their own psychiatric holds. That includes 5150s and 5585s. At the time, Santa Barbara Sheriff's Office was averaging about 5 to 8 mental health crisis calls per day. So I will say when I mentioned that out loud, most of the deputies in the room said that's low. So whether perceived or real, they felt like that was low. The average time to resolve a call in the field that's related to a mental health crisis is 1.5 hours. And the average time to resolve a call in the field that's not mental health related is about 20 minutes. So these calls typically are much more complex, as they should be, and often involve more deputies on scene than do non-mental health calls for service. We also looked at our jail population. And national data has estimated between 20 and 30 persons in jail have a severe and persistent mental illness. In our jail, we did a 1-day snapshot with our county mental health department. And as Lynne and George had said, that number was much, much higher that we saw. Next. So in June 2019, 330 persons in our jail were diagnosed with a severe mental illness. We talked about that second number. Interestingly, on the date of arrest, only 3.3% of the persons that were arrested were enrolled in treatment at the time, which tells us when people are in treatment, they're less likely to intersect with the criminal justice system. So we know that, anecdotally now we know that because of research that we were doing. We looked at our super utilizers. So by definition, those were persons that were arrested 5 or more times a year. We had 230 of them in 2018. And we looked at the top 100. So those are persons that were arrested 7 or more times. Over half of them were booked by one particular municipality, police department in our area. 63 had a probation violation. All but 5 had drug or alcohol charges. Most of them did not have a home address. And the significant majority of them had at one point in time been clients of our Department of Mental Health, whether that was in substance use or mental health or both. Next. So we are a part of the Stepping Up initiative, which George mentioned. So we got a big group of stakeholders together in one room at one time. And we talked about these issues and this data and what we could do to better impact the system to have better outcomes for those that are vulnerable, those with mental illness. So where law enforcement really comes in is intercept 1. So when that call to 911 is made or when local law enforcement are involved. So what could we do to better impact that system? Next. So this is the vote, I suppose you could say, the outcomes of where the persons in our county felt like we needed to make an impact. And 2 items on here that the Sheriff's Office addressed specifically and right away was expand CIT training and start a co-response team. Next. So as Lynne and George mentioned, the co-response team specifically began as a pilot project with existing funds and existing personnel. We, since the inception of the Behavioral Sciences Unit, sought out grant funding to expand the pilot program that was showing success. Success as defined as less people going to jail, less people getting arrested, less use of force, more people getting into treatment. And so there are 2 main grants that our county has right now that are due to end in 2022. One is through Prop 47, the other is through the Board of State and Community Corrections. The Prop 47 grant funds a lot of good initiatives in addition to a co-response team. Lynne mentioned diversion to where. So one of the wheres is addressed by Prop 47 and includes a drop-off center for law enforcement and transition center for folks that are leaving jail. And then the Burn JAG grant funds 2 co-response teams. So we went from 1 pilot program that started 1 day every other week to we now have 3 full-time programs, 2 of which are in South County, 1 of which is in North County. And we are working on getting more teams. It's really rewarding to see all the work and all the cool stuff that they do, but I'll have numbers in a minute. So next. So what is co-response? Co-response is pairing a mental health crisis worker and a CIT trained deputy in an unmarked vehicle dressed down, responding to calls for service for persons in mental health crisis. So their objective is to de-escalate the crisis situation, prevent injury to individuals, link them with treatment because we know they're less likely to intersect with the criminal justice system if they are in treatment. So under the interventions tab on the right-hand side, you'll see a list of different interventions the team can utilize. Everything from de-escalation to writing a psychiatric 5150 hold. And what's great about having grants is that we're tied to outcomes and data and research. So we have independent researchers for each of the grants. And so we're going to be able to report on all of this outcome data towards the end of the grant cycle. Next. Okay, so the numbers that I'm so excited about. So we'll look at, so the grants, I should say, started in February of this year. So the first month that we had data to report back is the month of March. So as a department, Santa Barbara Sheriff's Office in the month of March had 246 total mental health crisis calls. 146, or 59% of which were handled by one of the 3 co-response teams. And out of 146 calls, only 2 ended in arrest. Next. For the month of April, Santa Barbara Sheriff's Office had 275 total mental health crisis calls, 186 or 66% of which were handled by a co-response team, 6 of which ended in arrest. Next. For the month of May, 62% of all calls to the Sheriff's Office regarding a mental health crisis were handled by one of the 3 co-response teams, 3 of which ended in arrest. And I should say, when they end in arrest, that can mean a few different things. We'll always connect with our contracted medical and mental health provider, WellPath, in the jail and do a warm handoff and let them know exactly what was experienced in the field. And also some of the calls that the teams go on are not actually mental health related, but they're reported to be. And so some of those calls have ended in arrest, but we don't just stop our work there. We try to meet that person when they're released from jail and get them to treatment as soon as they're leaving, if that's the case. Next. For the month of June, the co-response teams handled 57% of all mental health crisis calls, which totaled 148, 1 of which ended in arrest. Next. And for the month of July, 67% of all calls to the Sheriff's Office within a mental health crisis were handled by a co-response team, 3 of which ended in arrest. And we can't talk about advocacy and programming without talking about dollars. Well, I can, but I've recognized in my position it just doesn't work. We're finding that the co-response teams are spending less time in the field than the average deputies are when they're on mental health crisis. So this is really an important point when we go advocate for these programs to be memorialized after the grant cycle, because this time equates to dollars. And so we're keeping track of this too. We also keep track of the areas that the mental health crisis calls come out of. So this gives you a little bit more of a specific breakdown as to where we're seeing the calls. Next. And last but not least, we talked about crisis intervention team training. So we're very proud at the Sheriff's Office to have led this effort in partnership with behavioral wellness. We have trained about 1,000 people in our county that have either had the 8-hour, the 40-hour, 24 or 36-hour custody course. Of the 1,000 persons, 657 are law enforcement and 150 are custody personnel. So we're not just training sheriff's deputies. We've trained every municipality police department in the area, including UCPD, airport police, probation, etc. So we have a really good standard training that we're providing to all different parts of the county, which is really important when we're talking about continuity of delivery of services and programming. We've also trained about 100 civilians. So from different nonprofit organizations, the Public Defender's Office, District Attorney's Office, Department of Behavioral Wellness, etc. Next. Okay, so thank you. Thank you to Nami for being such an amazing organization and really being the fuel jet for making sure that programs like this and initiatives like this happen. It's been my pleasure to work in this realm for the years that I have. So thank you. And I'm happy to introduce my colleague, Mr. John Winkler.
All right. Thank you, Cherylnn. And thank you, Nami, for inviting us to present on this topic. My name's John Winkler. I'm the Division Chief of Clinical Operations for Santa Barbara Department of Behavioral Wellness. Formerly the Crisis Services Manager before I was Division Chief. And so that's why that's my role today as Crisis Services Manager, along with Dr. Lee and Nami and quite a few other folks. We sort of rallied around and got co-response going. So we're going to talk a little bit today about that. Next slide, please. Next slide. So I want to start out by just giving a little bit of background of where we were before co-response started, and then what some of the hurdles were to getting co-response going and how we're trying to get that program sustained ongoing for quite a while. As Dr. Lee mentioned, we're unique in our county in that the behavioral wellness department are the only staff who write 5150, 5585 holds in the county. So it gives us a very unique perspective. And I think there's a lot of benefits to that, and there's some drawbacks, and I'll go over those real quick. One of the benefits is the training aspect. Because we're the only staff in the county that write holds, our staff can be really highly trained and specifically trained to do that role. We provide a yearly training for all of our staff. That's an all-day training on the LPS Act and probable cause. And a lot of patients' rights information is shared there too. Our patients' rights advocates are very involved in our 5150 training. And they really stress the LPS model of least restrictive environments and voluntary options whenever possible. The other benefit is frequency. Since our staff are the ones that are called out to write the holds, that's the only thing they do. That's their main role in the department. So they do it every single day. And obviously that level of repetition and frequency really adds to improving the quality of the 5150 assessments that are being done. Accountability is another piece of that. Every hold that we write in our county, that hold gets scanned to our patients' rights advocates who review it to ensure that voluntary options were explored, that least restrictive options were explored, and that there was truly probable cause for the hold. If that isn't the case, those holds get sent back to the team supervisors and get reviewed. So there's a constant quality assurance process that's going on with our 5150 process in our county. And last is the time. Because it's the only role that our staff do, our mobile crisis teams, they have the time in the field to do really very thorough evaluations. So they can spend sometimes up to hour and a half in the actual evaluation, but then they can also follow the individual to the hospital, present the case to the hospital, and do a lot of follow-up. So that's another big benefit. The results of those benefits are less unnecessary holds being written in the county, more of a focus on voluntary and least restrictive. We've been able to expand our less restrictive facilities in our county. We now have 3 crisis residential facilities, so up to 25 crisis residential beds, and we have an 8-bed unlocked crisis stabilization unit for less restrictive options. The other result is more appropriate use of LPS beds. As we know, unfortunately, in our state, there is a shortage of LPS beds. We only have 14 beds in our county, and those are only adult beds. We don't have any adolescent beds. So unfortunately, the beds are in short supply, so we really try to do everything we can to make sure we're appropriately using the LPS beds, and our 5150 process, I think, is beneficial to that. And less use of emergency department beds. Our county also does not have a county general hospital. We don't have any emergency psych services in our county, so every hold that is written goes to a local emergency department where they wait to go to an LPS placement. All of our emergency departments are privately owned in Santa Barbara County. 2 of the biggest drawbacks to this process is it's expensive on the front end for behavioral wellness. I'll talk about the budget piece of it later, but basically we act like fire department staff. We sit around and we wait for the call because we know we need to respond to the call right away. We can't be doing other things that we have to wrap up and complete before we get to a call. We want to get to the call as quick as possible. So there's some downtime on staff, and the way the county is funded is a lot of it through Medi-Cal. So if you're not providing a Medi-Cal billable service, you're not getting reimbursed, and that affects our revenue down the line. The other big issue that Dr. Lee had mentioned is law enforcement wait times. So when patrol deputies get on the scene, they quickly determine that this is a mental health call, not necessarily a legal call. It can take our staff 30, 35, 45 minutes, sometimes a little bit longer to get on scene, and that's a long time for law enforcement to be waiting. It's not a good use of the deputy's time. It also is a lot of opportunity for the situation to escalate and get out of control and for the crisis to become a little bit worse. So those are things we want to try to address with co-response. Next, please. So real quick, I think everyone knows Medi-Cal fee-for-service is our department's main funding source. So we provide a Medi-Cal billable service. We get reimbursed for that. That's the main chunk of funding that we get to run our department. MHSA funding is the other large portion of that. Some counties use MHSA funding for their co-response teams, but that was written into their plans a long time ago, and they get a lot more MHSA funding than we do as a medium-sized county. Our MHSA funds are currently geared towards other programs that we have up and running, so we didn't have MHSA funds available for co-response. Secondary funding sources are grants, general funds, and realignment funds. And grants is what we really focused on to provide at least the initial startup of the co-response teams in our county. And with Medi-Cal reimbursement, you're only reimbursed for the actual crisis evaluation. A lot of the other services that co-response are doing that are so important to the program aren't Medi-Cal reimbursable. So that's, waiting around for the calls to come in, a lot of the outreach and engagement, proactive and follow-up services that Dr. Lee was mentioning. Those are really vital components. Those are the things we want to be doing the most of. We don't want to wait to intervene for when a crisis is happening, and those aren't Medi-Cal reimbursable. So where do we get the funds to support the staffing for those types of services? That's where the grant funding came in. Next, please. So I think George had sort of mentioned our crisis action team. Our department has a number of different action teams. So these are meetings that we hold monthly for the community stakeholders to come in and provide feedback to our department and to work collaboratively to address certain issues. So we have a forensic action team, a housing action team, and we've got a crisis action team meeting. So the goal of the crisis action team meeting was to really focus on the high utilizers, LPS hospital utilization, ED utilization, and try to figure out a way to streamline the process, provide the best services possible to individuals, do a lot of proactive services. So as part of that discussion, one of the meetings we had, George Kaufmann and Lieutenant Eddie Schway, who's now retired from the Sheriff's Department, but Eddie was a huge champion of mental health services within law enforcement and appropriately addressing mental health issues in law enforcement. He and George presented at the crisis action team on co-response. They had gone to a conference, and I think it was LA and San Diego County had presented on their co-response teams. They brought it back to the crisis action team, and everybody, their kind of eyes open and their jaws dropped, and we said, this is what we need to do. This is exactly what we're facing in our county. These are the hurdles we're trying to overcome, and this would be a great opportunity for us. Both of our departments, the Sheriff's Department and Behavioral Health Department, we're already kind of integrated. Because we're the only ones that write holds, we go out to every mental health call that law enforcement is facing. So we already knew a lot of the deputies. We already had a close working relationship. The Sheriff's Department was very involved in our crisis action team meeting. So co-response, we thought, was just going to be easy, seamless, and go really smooth. So we began to address the stakeholder support to see what we could do to get the program going. Next, please. So the main stakeholders, at least initially with co-response, obviously was law enforcement. Because of the response time for mobile crisis, we knew that co-response was going to address that and alleviate that and free up patrol to do what patrol needed to do. As Dr. Lee mentioned, with CIT and co-response, it's also drastically helped with reducing use of force, and it's also a big part of jail diversion. So law enforcement, obviously for all those reasons, saw co-response as something really beneficial. We just had to figure out how to pay for it. Hospitals were the other big stakeholders. Because we don't have a county general hospital, we don't have any emergency psych services, all of our mental health clients that are in crisis end up in the EDs. Either they self-present there or they're brought there by law enforcement after a hold is written. There's a lot of high utilizers that circle through the EDs. So the hospitals really saw co-response as a way to divert some of those folks from the EDs and get them into treatment where they really needed to be. So they were on board. And then, of course, Nami, for all the different reasons we've mentioned. They've been huge champions of this and have really helped to get the word out there and the stakeholder support and really work with our CEO's office and Board of Supervisors to help them understand how important the program really is. Next, please. So Dr. Lee kind of already mentioned the grant funding. We had the initial pilot, which was supported by existing staff, and we just kind of pulled it together by the shoestrings, I think, and made it work. But we knew in order to keep it going, we had to get some funding somewhere. So Prop 47 was one of those grants that we got, and then the BIRD JAG grant was the other one, and that's helped to support the next phase of co-response, which is the 3 different teams that we have going right now. Dr. Lee mentioned data collection in order to make this program ongoing and really show how beneficial it is. We need to show some data. So we're working on patrol time, diversion from arrest, diversion from ED, and the things that Dr. Lee was mentioning. So as I mentioned, our mobile crisis program, that's an expensive program up front. But what we're really trying to show is that co-response is actually really saving money on the back end. We might not have funding, Medi-Cal funding for the staff, but we're keeping folks out of the emergency department. We're keeping them out of jail. We're keeping them out of crises in the first place. We're getting them into services that they need. So on the back end, I think we're going to show that we're saving quite a bit of money, as well as the most important thing is providing appropriate services for the individuals in our community. Next slide, please. So some other strategies that we're looking at with our behavioral health department to keep co-response going. One of those is giving authority to hospital emergency departments to write and rescind their own holds. So prior to the co-response pilot, we were the only staff doing 5150 evaluations. That includes in the hospitals. So hospital psychiatrists and doctors were not writing holds or rescinding holds. That was all our responsibility. Our staff were spending a great deal of time in the hospitals every day, evaluating, reevaluating, bed searching. So we worked out a plan with the hospitals to provide them authority to do some of that work, which has freed up quite a bit of staff time on our end, and some of that staff time was diverted to our co-response pilot. The other thing we're looking at is just staff utilization. We typically had 2 staff, mobile crisis staff on night shift. And looking at the data, we realized that we don't really get a lot of calls overnight. Law enforcement is always involved in every one of those calls. We didn't really need to have 2 staff on overnight. So we've shifted to 1 staff on, 1 in the South County, 1 in the North County. So that's helped, again, to divert some staffing resources to co-response. And we're also looking at shifting our crisis services to also doing access calls overnight. For now, we might start doing that in the day shift too. But every behavioral health department has to have a 24/7 live access line. That's required by the state. And right now we have access staff doing that, not crisis staff. But by bringing the crisis staff in, there's a way to bill for some of the time that they spend waiting around. If they're waiting around and there isn't an active crisis call, they can be taking access calls, and there's a back-end way of billing Medi-Cal for that service because it is reimbursed by Medi-Cal. So again, that's just another way of saving some money and some staff time and resources so that we can try to make co-response sustainable in the long run. Next slide, please, if there is one. And lastly, we've also been working on some co-response programs with our local police departments, especially Santa Barbara PD has been very interested in co-response. We did start a pilot with them. They had some other funding that they were using for homeless outreach, and we kind of tag teamed with the police department to start a co-response pilot back in 2019. With COVID and some other things, that kind of fell off, but we're back in talks again with PD about getting a co-response program going. I know we've also been, Dr. Lee, I think, and us have also been working with Santa Maria PD to see if we can get them on board. We really want to get the whole county jurisdiction covered with co-response and not have any issues with cross-jurisdictional borders or particular police departments not wanting, this program. We think it's beneficial for everybody. Our clients certainly don't adhere to jurisdictions. They move all over the county, and we need to be able to provide that service quickly. So we're hoping that our local PDs will also get on board with this as strongly as the Sheriff's Department has. So I think that's it for me. So I will pass it back to George to wrap it up. You're mute, George.
Thanks, John, and thank you, Lynn and Cherylnn, for your contributions here. There's some couple of things that each of our speakers mentioned I just wanted to bring special attention to, because I think if you're entertaining doing this sort of project, there are a couple of really critical success factors that we found in doing this. The first was that the whole success of projects like this depend on the ability to kind of break down the silos. And it was amazing to me to see that there are even silos within departments sometimes, you know, and that need breaking down. But when you get the right people together in the room at the same time, and usually that leads me to the second point, usually they're operational level people. So, I mean, there's a place for the executives and all that, but what was amazing to me was that when you got people who were on the ground, whether it be in the sheriff's department or in the behavioral wellness department, that were dealing with the same issues every day, and you got them talking to each other, things started to happen. And so I think a lot of the benefit of this project was seen in just connecting the right people and say, hey, did you know that we have this service here, or we could help you with this, or could you help us with that? And first thing you know, a lot of the kinks in the system, all the systems got worked out. I think it's a really important thing, especially in public projects like this. The other point that I put up there was the use of the quote pilot project, and in our county, it's sort of a euphemism for when everybody wants to do something, but we don't have any money, you know. And so, as John alluded to, you know, we figure out ways, and I think Cherylnn did too. We figure out where we can take and shift maybe existing resources in a way to sort of do a demonstration project, and which we call a pilot project. And I think this is one of several projects that our county has undertaken in the mental health area recently that had to start out as a pilot project because there just wasn't funding for it. Assisted outpatient treatment was another one, which also got implemented through beginning as a pilot project. So just, I guess my comment to Nami's out there is, when your mental health department and your sheriff's department say, we'd love to do this, we don't have the money, challenge them to figure out a way to work together to find out how could we do it, even on a small scale basis in the beginning. And if it works, like you saw that this program did, then it becomes relatively easier to find other sources of income for it. So that's the pilot project. And I think the other thing that was key is that we really did have a broad coalition. Lynne mentioned that it wasn't just Nami, it was the League of Women Voters, it was the housing groups, it was other people, other mental health groups in the community. And I think the more individual community stakeholders you have involved, the closer your government agencies and departments will listen to what it is that you're advocating for. And then another thing is just sort of out of the box thinking. And I don't know, John didn't mention this, but one thing that just really intrigued me was that when they're trying to figure out a way to justify taking a mental health worker and putting them with a sheriff's deputy, even though there's going to be a lot of downtime, you know, somebody had the idea to, well, you know, maybe we can make wellness checks, you know, on folks that had previously been recipients of crisis calls, you know, and in many cases those calls were billable, you know, and so that's another way to try to look at defraying some of the costs. So it's sort of out of the box thinking, or thinking on your feet, I think, that often makes projects like this work. And finally, last but not least, of course, we have to thank pat ourselves on the back, our own Nami advocacy, and really the extraordinary leadership of Lynne Gibbs, who over the years leading our advocacy efforts in our county have won a lot of respect for Nami, not just with our departments, but with our board of supervisors in our county. And I think a lot of the success we've had has been due to the development of those relationships. So with that in mind, we're anxious to get to hear what questions and comments that you guys have. So thank you very much to our participants today, and let's open it to questions. Okay, so let's start with a couple of questions that I managed to write down early on. And Ragini, if you can, if I miss some, you can remind me. Okay, I was just sort of jotting down some of them as they came in, and I'm not going to answer them all, but I'll try to direct traffic among our 4 folks that are here. So you see, Dr. Cherylnn Lee is here, and Lynne is here. Lynne Gibbs, our public policy chair, and John Winkler is somewhere, although he's further down on my screen, so I can't see him, but he's going to be participating too. So the first question that I noticed even before the group started, somebody asked the question about how this program compared to the one in San Diego County, the PERT program in San Diego County. And you might have caught it in, I think it was in John's presentation, that that was really what went before in Los Angeles County and San Diego County actually formed the basis for us bringing this idea back to Santa Barbara. In fact, the conference that John referred to, it was the Nami California conference, I think in either 2016 or 2017, where we actually had presentations on both the LA program and San Diego program. They kind of got Eddie Shui and I jacked up on this and then to bring it back. So it's very much the same, although as you can imagine, with the larger infrastructure that exists in a larger county like San Diego, it's probably, their programs are probably in some ways more comprehensive than ours, but the fundamental activities of what happened are pretty much the same. It's a mental health crisis worker teamed with a special CIT trained law enforcement officer working as a team out of the same car to respond to crisis calls with the goal of de-escalating a situation and funneling as many people into treatment as possible and minimizing the number of people that actually experience continuing law enforcement involvement. So in that, I hope that answered that question. So another question that came up that I noticed was CIT training after COVID. And Cherylnn, you might want to mention that. I think the question was, what have we done since COVID? Has that put the brakes on CIT training? And how are we handling that? And
Great question.
That's probably a common problem across the state.
Yeah, so there are some counties who continued with their CIT training virtually during COVID times. Our county opted not to do that. Our first CIT Academy since COVID started in March will be held in December. And so we're accommodating for COVID. So we're having social distancing. We're going to check everybody's temperature. For the panels that we have and the guest speakers, there's going to be an option to Zoom in so that they don't have to be in person with the classmates. So that's how we're handling the academy. We have done 2 8-hour CIT courses at the request of different police departments, and everybody wears a mask and socially distances, and I bring individually wrapped treats instead of big boxes of sugary snacks for everybody. So we've been able to keep on in a modified way. Personally, I don't think there's as much value in doing virtual CIT training. Like I mentioned, some counties have opted to do that, but we have not.
Right, thank you, Cherylnn. So another question that came up, I think this one's probably for you, John. You mentioned that the funding issues around mental health crises and the fact that the longer term services aren't reimbursable, just the first contact. The question is, how's that handled with people with private insurance? Oh, you're still muted, John. You're still muted, John.
You're on mute.
No.
Sorry, I was trying to unmute, but it said the host wouldn't let me unmute myself. So I kept clicking the button and nothing was happening. So for privately insured, yeah, since Our department handles all the crisis calls, regardless of whether or not the person's privately insured or has Medi-Cal. We still handle the call, but we just kind of have to eat that cost. We don't bill private insurance for crisis. We've tried in the past, but it just hasn't really been worth it because we don't have contracts, MOUs, and all of that kind of stuff with the different insurance companies. But if we do write a hold on someone with private insurance, we do do the bed search. So we do make sure that we find an appropriate inpatient psych bed for that person. Or if we don't write a hold, and we safety plan, we work with that within that person's insurance company and insurance providers to provide a safety plan with ongoing mental health care referrals.
Good. Thank you. Yeah, I think it sounds like some other counties aren't that magnanimous to eat the costs.
George, could I respond to a question I'm reading here?
Sure, go ahead.
Someone was asking how he or she can get information that will help me explain and educate regarding de-escalation technique, purpose, and intent. There are several wonderful YouTube videos that cover de-escalation. And I think it's something where a picture is kind of worth 1,000 words. When you see a simulation of a successful de-escalation, you go, yeah, I can see how that works. I can see how the officer responded in a different way and gave the person some reassurance or let them know that I was on their side. And how that furthers the process of stabilizing somebody who's in mental health crisis. So I would recommend going to YouTube and searching on CIT or de-escalation training and maybe showing those videos.
Thank you. Do you have anything to add to that, Cherylnn?
Yes. One of the first things that we cover in CIT is how do we define the word de-escalation? So if we look at the Webster Dictionary, it'll have one definition. If you ask a cop, they'll have their definition. If you ask a community member, they'll have their definition. So one of the things that we set to do from the beginning is coming up with an operational definition for the class. Because you're right, sometimes you'll ask a law enforcement officer and they'll consider de-escalation a use of a taser. And that is not okay for some families. That's not what, civilians or folks would consider de-escalation, although in the law enforcement world, that's, that's verbiage that they use. And so I think when we talk about the phrase de-escalation, we have to have an operational definition depending on what group we're in, so that we're all talking about the same thing. But yeah, depending on your audience, it's going to mean something different. So it's helpful also to ask or to look at the policies of the municipalities that you're dealing with, the different law enforcement agencies, because even different law enforcement agencies may have different definitions of what de-escalation means to them. So absolutely. Yeah.
Great, thank you. While I'm reading the next question, one of the other ones that I picked up as we're going along was, and maybe Lynn, this is something you can comment on, and John and Lynn and Cherylnn, if you can add to it, fine. But the question was, how does this program intersect the co-response, I assume they're talking about, with the issue of homelessness and the relationship between, I guess, the hidden question is sort of the relationship between crisis and homelessness.
I think Cherylnn and John could probably respond more directly to the linkage to assessment for housing, but clearly a number of cases that law enforcement and behavioral wellness need to respond to in mental health crisis are people who are homeless, and Cherylnn covered that in her statistics. So it can serve as an entry point to review for a process called coordinated entry to make someone eligible for housing.
Yeah, I think part of the benefit of this program is you have a clinician in the car with law enforcement, and that clinician works for a larger agency that has different ways of accessing services. And so that clinician is often a conduit for outreaching to the homeless services portion of behavioral wellness or other folks within John's department that specifically focus on that piece of it. So there's a lot more continuity going on than just de-escalation in that moment on scene and getting that person to the next step of where they need to go in the process. There's a lot more that goes on the back side of things.
Okay, thank you. John, you got anything to add there?
No, I just say a lot of the work that our co-response teams does is with folks who are homeless. It just tends to be the homeless folks that really end up on law enforcement's radar quite a bit. Law enforcement gets a lot of calls for disturbances and other things. So we outreach to a lot of folks and work closely with our homeless services program within the department to get them on the prioritization list and into either shelter or some type of supported housing programs.
And that's a good point that John reminded me of, is that a lot of the calls that we get for persons who don't have stable housing are what law enforcement likes to call do something calls. So a community member sees somebody and they want law enforcement to do something about it, and there's often no crime committed. This is where the team can be really effective because you don't have a crime, so what's the need for law enforcement to be there, but there's a call in the queue, so law enforcement has to respond. And so that's a lot of the calls that we get for folks that are homeless, the do something calls, where we can really make some magic happen.
Great. Anything else? Thank you. So next question is, does the pilot program address the specific mental health issues of military service members, veterans, and their families? Who wants to take that one?
Go ahead, Cherylnn. You're really familiar with some of the services with our veterans in county.
Sure, and I'll have to qualify this by saying if you hear any strange noises in the background while I'm speaking, it's my 5-week-old that has joined us on the Zoom call. So, so I'll just leave that there. So we partner with some special organizations, nonprofits in the county that are specifically trained in and set up to support those that are military and veterans. Some of our co-responders, deputies and clinicians, have history, either themselves being in the armed forces or family members, or have done work in that arena. And that is a specialty group that has access to certain services or needs different kind of assistance than the general population might. So, in CIT and co-response and these programs that we've built and are building on, the most important thing, in addition to the funding, I think, and the motivation, is the relationships. And so we've made great relationships with those in our community that support military and veterans. And because of that, when the team encounters somebody that has that background in the field, they pick up the phone, they call Stephen, who operates this program, and then Stephen gets his ball rolling and the person gets connected. So relationships.
Great. Thank you, Cherylnn. Anybody else have anything to add? Really good question, the next one. I want to make sure we get to this one before we run out of time. Do any of you have firsthand experience with CIT trained officers or the co-response team? If so, how did they perform? Let me see if it's a different question or the same one. Are you able to share the difference between CIT program? Oh yeah, I already did that. Yeah, so Lynne, I don't think you or I have had firsthand experience with our family members.
I have.
Okay.
Yeah. About a year ago, my daughter needed to be hospitalized under a 5150. And whereas a number of years past, we were very frustrated in trying to get a needed 5150. I was able to contact the behavioral sciences unit, and she had a visit from co-response, and she was able to get the treatment she needed, and she's now back in her apartment again and doing really well. But I was just so grateful that we had that co-response program.
So
Sometimes you work on something and you wind up benefiting personally and you don't even expect that. So that was nice.
Thank you. The only thing that I would add, I don't have personal experience. My son lives in another state, and thankfully he's had a great recovery and is not involved anymore in law enforcement. But one of the ways that I knew it was working is that I help co-facilitate, or I attend one of our weekly family member support groups. And we always heard stories perpetually, horror stories about contacts with law enforcement around mental health crises. And since the institution of these teams now, we're hearing exactly the opposite. People come in and say, you know that co-response thing you talked about? Well, I called just like you said I should, and I asked for a co-response team, and I guess they sent one because we had an entirely different response than we had the first time. And instead of my loved one being dragged out of the house in handcuffs, they actually were able to, in a few cases, they were able to actually prevent the need for hospitalization. And in a couple of other cases, they were able to get a prompt analysis or prompt evaluation, and then have them receive the hospitalization that they needed. So we can just see it. And it happens, I would say, once or twice a month in our support groups. We have a story that comes up like that. So, you know, while I don't have personal experience, it's really compelling, the response. So have we got any other questions that I've missed here?
I see one here, George, asking about crisis teams not always working at night. Is this because of safety? And I'm not sure if they're talking about crisis teams that are funded through the county mental health plan. I think in a lot of cases, it has to do more with cost and funding than safety. In Santa Barbara County, our team has always operated 24/7. But that's because we're the only entity that can write holds. So in other counties, if they're not working at night, then that duty falls over to law enforcement, and law enforcement probably writes the holds or does the crisis de-escalation in those counties. So again, it's why co-response is great. If we could do co-response 24/7, that would be fantastic, because we do get calls at night, and we would love to be able to have co-response operating at night too.
And I'll add to that, if the question was specific to co-response and how we chose the hours that we did, we looked at the data from dispatch from our sheriff's office and what days of the week and what times of day the majority of the mental health crises calls were coming in. And it just so happened that they tend to be between the hours of 8 a.m. and 6 p.m. Monday through Friday. So the team right now, those are the hours that the teams work, because that's what the data shows us. I agree with John. If we can get teams 24 hours a day, 7 days a week, there's always a need for that. But the majority of the sheriff's office calls were coming during those times, which is how we chose when they work.
Okay, thank you, Cherylnn. I'm still scrolling down here. Boy, you guys have really gotten involved. There's just a tremendous number. If you haven't read the chat box, there's a lot of comment, and a lot of it is just statements about different experiences that folks are having, not necessarily in the form of questions, but it's worth reading. Here's one. How do you foresee CIT changing with the implementation of 988 in 2022? Cherylnn?
I'm not familiar with 988.
I didn't know that it had been approved, but I mean, there's been a proposal, I think, to have an emergency mental health line like 911, but just for
that I've heard of. Yeah. So how do I see it changing? I see it as an additional referral source, because, you know, folks on the other side of 988, it's a phone number. And, you know, if there needs to be an emergent response, I would imagine that person on the other side of 988 is going to call 911, similar to the way suicide hotlines run. And ideally, that person would have a direct line to the co-response team. But I don't see it having a huge impact except another potential referral source.
John, anything to
No, I would agree with that. I wasn't as familiar with that either. So,
All right, I guess this is it. We're at 3 o'clock, and I think unless I've missed something, I think we've covered most of the questions.
I can send any of the extra questions to y'all if you'd like. I can combine it and then send it. And maybe we can post something on our Nami California website. I know a bunch of our sessions, we have so many people, so we obviously can't get to all the questions. But we plan on having something like a combined kind of Q&A kind of section on our websites for everyone to be available. So that's something maybe to expect, George, and I can like maybe combine some and send it to you. Is that okay?
That would be great. If you do that, I promise we'll get back to you. Well, I don't promise we'll have an answer, but we'll have a response. Okay.
Yeah,
And then
that
also,
works.
I went ahead and put my email address in the chat box, so anybody that wants to email me is welcome to do that.
Yeah, and can we do that for? I mean, I would be happy to do that too. I don't know.
Yeah.
I'm a computer Luddite, so I don't know how to do it. But if you could put my email address up there, people are
Sure
welcome.
thing. Let me do it right now.
Sure.
All right. I'm putting up George's email for everyone. Definitely send them an email. This whole team is just amazing. It's been amazing to work with, George and all of you. I know I just met majority of you today, but it's been amazing. And then also, is it okay for me to post the link of the video into the chat box as well?
Yep.
And so everyone can have access to the slides. We'll also be posting this whole recording and everything later on, and to I think Lynne, who's been the project lead, she's going to be sending it all too. So everyone's going to have a bunch of materials. No worries.
And it's also going to be available on YouTube. So I mean, you'll have lots of ways to access it.
Yes, definitely. All right.
Thank you so much, Virginia.
Thank you.
Thank you,
I really
everybody.
appreciate everyone here.